Bloomfield Hills, Michigan. And so, very interesting case. Nice lady from Canada. Uh, she comes in with a set of implants that she has from the year 2000, and what are basically salient implants from what she has said. And so she had a grade 4 capsular contracture, meaning a hard deformity of the chest plus pain on the right and also on the left. And a couple more she had what was the left one. As you can see, this had essentially deflated, and the right one literally is like a ball. It's like a ball, and you can see how it is protruding out here. Done end block, the gold standard. Complete end block, 10/29/25, initials EB. I reviewed a case yesterday. A patient had a supposed end block, and there was no initial, so it's important to write down and to document exactly what was done. So inflamed tissue I removed on the periphery on the side. Anything abnormal, irregular was also removed, and it's calcified hard, and you can see it's like literally a round ball sitting on her chest, pressing the skin such that it was stretching it out. So I removed this excess skin, as you can see right here. And then what was this right mass? It's very hard, and if you feel it, it does not belong in the chest. This was at the superior part. And I'm going to send this as a right chest mass separate. And as you can see, as I cut this open, it's like all scar tissue. And I am going to see what the pathologist says about this. Very hard, indurated. So now, having said this, I am going to go ahead and cut open this right grade 4 capsular contracture hard mass. I'm going to go in from here. You can see how this inflamed tissue, believe it or not, has to be removed as much as the capsule, because remember, you can see, look how abnormal, inflamed, irritated this is. And this is where, as I go in, actually let me find an easier path. Anything abnormal, irregular was removed. This was on top of the pec major, the fascia of which was removed as well. And as I go in, this is super tight, as you can imagine. I'm going to go in from here. Hopefully I'm able to find the right entry point. Very tight. The goal is to remove all that tissue, leaving behind the good precious volume. Remember, this is all bad tissue. This is all bad tissue. You can see it's all scar tissue. I'm going to find a good entry point here without hurting the implants. Let me go in from here. I'm just going to start till I hopefully find something that's going to be reasonable. Again, this is all bad tissue. Let's see right here. Remember, it's relatively very, very hard, tightly adherent. Let me go in here. There we go. So this is the reason why I chose to go in here. calcified. No one should have to live with a contracture, by the way. It's not healthy to live with a solid mass. You can actually hear it being cut. And as I go in, everything contained. Sometimes I've seen fluid. It's like a hard shell that you've seen this many times before. It's calcified. Now, I want you to go ahead and see how this is literally suffocating on itself. I'm going to go in here. A little bit more than I'll pull it out. So the whole goal here is to do end block so there's any fluid, anything on the inside that is removed completely, definitively, sincerely. And none of this, if there's any fluid, should spill into the chest. Alright, let me go ahead and pull this out. Okay. Again, goal is to go slow. I'm going to finger dissect here. All contained. Nice lady. She's literally, I would say, memorized almost all my videos. She understood how I did it, why I did it, in the manner that I do my surgeries. What is called part of the informed consent. And lo and behold, look at this. Look at the shell. So if I take my gloves, you can see this pasty type calcified tissue. The other thing I want to show here is if I flip this open, you can see my green glove. This is how thin it is. And if I put it on a ruler, you will read the ruler. It says 2 right there, 1. And so the bottom line is no matter how thin, it has to go, and one has to always assume, who knows, it could be a silicone implant on the inside, because remember, she had it done outside of the US. And these are the hard scales of a fish, if you will, right here. So the entire capsular tissue is going to be sent to pathology, hard like a, and you can see, look at this leprosy thing going on here. So you can see on the inside, this is your 275, and you can see how the implant is kind of beat up. I'm going to send this off with the 275 and overall intact, but I would say overfilled implant. So mass will be going separately, this will be going separately, implants to be returned to the patient. I'm very grateful to the patient for allowing us to share her journey and the course. Now look at this. This is a ruptured, brand new gloves, sterile gloves. So left side, grade 4 capsular contracture, full thickness skin removed for contouring purposes. And as you will see, this implant has essentially ruptured, and it's all contained by the shell. And this is where, what I'm going to do here is, if you can please get me one of these basins. There should be a basin right here. Yeah. So I have a sterile basin right here. I'm going to go ahead and this is what we use. So sterile basin with sterile saline. So I'm just going to open it in here because if there's any fluid, I want to contain it. And you have to always be thinking badness. Anytime you do any explant surgery, you have to be thinking the worst case scenario because you don't want to be caught off guard. And you have to be always prepared. And that's why you have to go slow with the dissection. Slow meaning leaving behind all good precious volume. You can see, look how angry and inflamed this is. So this is going to be a little bit easier to cut into because it's not as tight as you can imagine. Here's the calcification. I don't want to go there yet. Let me go and I'm going to palpate an area that's soft. Literally, I feel like there is sand inside. But let me go in here again. So there is a certain etiquette when it comes to removal of the there we go. So this is why the end block is key. Just 1 second. I'm going to rest this here. No, I got it. You're good. One more, do you have this, please? Two. So look at this. Creamy discharge. And what I'm going to do is, this is where I'm going to go ahead and just pour it here. It's literally like milk. We've seen this many times before. None of this spilled into the chest. Now, it reminds me of a case that I did a few years ago. We took cultures of this and it came back as bacteria. This is a few years ago. Obviously, we are thinking here the worst, and I'm going to go ahead and pull this out. And this is why the end block is key, and you can see this is all removed, and I'm going to cut this open. I'm going to invert this open. Very hard. This is like the scales of a fish. If you see the back of my hand, none of this spilled into the chest, and this is where no need for drains, right? This is why she came to me, and she was actually excited about her surgery, very appropriately. I'm going to send this. And this is indeed what is a 275 implant. Now what I'm going to do is I'm going to put this open, press this. So we actually see the leak right here, guys. Right here. And another one up there. See from this. There you go. There you go. This is the leak right here. All contained. And this fluid I'm going to send to. I'm going to send this off to pathology. So a lot of fluid, all contained. None of it got absorbed. And you can see relatively viscous, and everything contained. No need for drains in her. This is not the time to be doing lift, and very likely, hopefully, she will not need a lift as well. So this is supposed to be the nicer, better, safer saline implant, and you can see that you never know what you're going to find. So take home message: the surgeon has to always assume the worst. Number two, always assume there's fluid on the inside, even on what is supposed to be a new implant. Because there can be around a normal, like a silicone implant, you can still have fluid around because this is the inflammation. Any abnormal masses have to be removed and sent separately just so that we know what it is and what it is not, including that very rare BILCL, breast cancer. The implants will be returned to the patient. As you can see, look, this was already heading how tight it was towards a rupture. The end block was done on the right and also on the left, everything contained. The right capsule and the left capsule will be sent to pathology, right chest mass to be sent to pathology. I'm going to send the fluid to cytology for ruling out the BIALCL. And this is where you never know. It's like a big mystery what you're going to find on the inside. No one should have to live with a capsular contracture. If you're having pain or hard masses, be it a grade 3 capsular contracture, you should go seek attention by a board-certified plastic surgeon so you get the care and attention that everyone deserves. Anything that is removed is sent to pathology to rule out the badness. Anything even remotely suspicious is also removed. Only good, healthy, viable tissue remaining behind. And this is what I would say with definitive certainty. 20 years from now, I cannot imagine anyone else doing the surgery any different, any better. Yes, it is invasive, but this is thorough and complete. And I will end up with what is the 7 parts of what is the con procedure. No need for a drain, no need for a lift. Certainly, this patient will do well. The capsules are sent to pathology, rule out the BIALCL. Culture is done for aerobic, anaerobic, and fungal. Liquid that is seen sent to cytology separately. Twilight, deep sedation, no paralysis. No matter what the age, the patient gets the same surgery regardless of the comorbidities, and block the gold standard. And the patient's going to get high definition pictures and videos. Obviously, this is there for her to see. But more importantly, of the chest wall showing complete removal. This is the thing that kind of seals the deal, if you will. High definition pictures and videos of the chest wall showing complete removal of the capsule. If you're not shown that, it was not done. And in my practice, I give it to my patients as soon as I say hi to them as I enter the patients. Yes, this is involved. It's a very thoughtful, systematic approach. And we will continue to see and hear from what the pathology says. So there we have it. This is Dr. Khan, Executive Plastic Surgeon.